timing was striking. Traditionally, the flu season in Quebec might not fully take hold until later in the year, often November, perhaps peaking after the holidays. But this year, the virus seemed to be stirring early. JGH, as part of the CIUSSS West Central Montreal network, observed a surge in influenza cases ahead of schedule. In that sense, the hospital's decision felt as much preemptive as reactive, a measure to brace ahead, rather than wait until the storm fully broke. A decision against the grain. In many respects, this move is emblematic of a shifting paradigm in how healthcare facilities manage risk in the post-pandemic era. The mask mandate debate, once a flashpoint of public policy, has settled into a more nuanced posture. Masks may be optional in many areas, yet still required in settings where the stakes are high. The Canadian Medical Protective Association notes that healthcare centers often ask patients and visitors to wear masks when respiratory virus rates rise. And JGH's policy reflects exactly that posture. When the local data say the risk is rising, reinstating masking is a valid layer of protection. Yet there is also an undercurrent of caution, of balance. The hospital's statement emphasizes that the measure, which is based on the ever-changing circumstances, is reviewed and adapted regularly. That language signals humility. The hospital recognizes it cannot permanently enforce all restrictions, but must be nimble and responsive. This is less about returning to the heavy restrictions of pandemic days and more about embedding preparedness into routine operations. The invisible threat of an early flu surge. What does it mean when the flu arrives ahead of schedule? For health systems, it means the ramp-up time shrinks. Staff may not yet be fully in seasonal surge mode. Beds reserved for elective procedures may become occupied by unplanned admissions, vulnerable patients, who come to the hospital precisely because they need care, face increased risk of acquiring infections while they are in care. The hospital, recognizing these risks, takes the mask decision as part of a broader resilience strategy. Masks, in this context, serve dual functions, protecting the patients from staff, who might unknowingly carry a respiratory infection, and protecting staff from patients or other staff. As the CMA guide puts it, hospitals usually require masks whenever rising respiratory virus rates threaten everyone's health. In a setting where both the patient and staff populations contain vulnerable persons, prevention is worth the might-be-perceived inconvenience. Implications and ripples. Individuals walking into the hospital may barely notice the change. Masking is already familiar. Staff may don them routinely in particular units. But for many, it will feel like a reminder. The viruses we thought dormant or past their worst are still circling. The broader public may read the hospital's move as a signal. If a major hospital is reinstating a mask mandate, perhaps the risk is higher than we thought. On the organizational level, this decision likely ripples into staffing, supply, scheduling, and communication. If more staff use masks, and possibly more will get mild respiratory illnesses but still aim to work, how does the hospital adjust? How are visitor policies shaped? How is patient flow managed? The hospital's statement allows for adaptation. One wonders what internal triggers will prompt rollback or further escalation. The ethical and social dimension. There is something quietly ethical about masking in hospitals. It is a gesture of care, not merely for oneself, but for others. When a clinician wears a mask during a patient encounter during respiratory virus surges, it says, "I am protecting you as you come here for care." Visitors wearing masks say, "I enter this space aware of the risks around us, and I will take a small step for communal safety." Masks also evoke the hidden connectedness of human health. We often think of illness as an individual matter. I caught the flu. But in a hospital, the flu is a network issue. Staffing, patient safety, immunocompromised patients, transmission risk. Thus, an early flu surge threatens not only individual patients, but the entire system's ability to deliver care. Masking is a low-cost, high-impact step in that system-wide resilience. Looking forward, what does this teach us? First, vigilance must be ongoing. The fact that JGH reinstated mask mandates ahead of the traditional peak suggests that health systems must let data, not calendar seasons, drive policy. The autumn air may still feel mild, but the flu may already be incubating. Second, flexibility is key. The hospital's framing of the mask policy as something under regular review suggests that there is no fixed on-off switch for masking. Rather, it is a tool in the toolkit. Prepare, implement, review, adapt. This mindset may become the norm in future seasonal virus management. Third, messaging matters. Communicating the reinstatement of masks without causing alarm is a tightrope. Patients and visitors must feel assurance that safety is being taken seriously, but not panic that the hospital is in chaos. The balancing act of transparency, calm, and action is delicate. Fourth, prevention is still better than cure. Masking may seem old hat after the height of the pandemic, but its reemergence here underscores a timeless principle. When risk is elevated, simple barriers matter. The hospital does not need to leap to extreme measures. Masks, offered to staff and visitors, suffice for now. A story to illustrate. Imagine a patient, Ms. Riviere, 81 years old, admitted to JGH for scheduled surgery. She's anticipating 3 days of recovery, keen to get home for her granddaughter's birthday. At check-in, she notices that the nurse is wearing a mask, the unit is quiet, the waiting area chairs slightly more spaced, and a sign reminding visitors that masks are available. Ms. Riviere thinks, "Good, I'm safe here." She relaxes. Meanwhile, in the background, the hospital's infectious disease team is reviewing flu surveillance data, an earlier-than-usual surge. They decide to activate the mask mandate across high-risk zones. A small ripple, but for Ms. Riviere and dozens of others, it may be what prevents a hospital-acquired illness. That's the unseen benefit of the mandate. Closing thoughts. In the evolving landscape of healthcare post-COVID, moments like JGH's decision feel both familiar and novel. Familiar, because we've been here before: mask mandates, virus seasons, hospitals tightening protocols. Novel, because we are attempting to normalize a dynamic response, one in which precaution is not extraordinary but part of everyday readiness. As the cold weather creeps in and respiratory viruses begin their seasonal dance, the mask mandate at the Jewish General Hospital is less a return to the past and more a reaffirmation of a principle: that care environments must adapt faster than the viruses that challenge them. For patients, staff, and visitors alike, this remandate is unspoken assurance. We are watching, we are caring, we will do what's needed. And so, in a quiet hospital wing in Montreal, the masks appear again, not as symbols of fear, but as gestures of vigilance, of community, of unheralded protection. The flu may have come early, but the hospital's